With that, welcome to October, everybody. Gotta be honest with you, I'm not quite sure how it's October already.
I have a pink shirt on.
Oh, that's true. Scott is wearing a pink shirt. There actually is legislation to prohibit Scott from wearing a pink shirt at any time except in October, which is probably for the best. Which is probably for the best. May I have a motion to approve the September minutes, please?
That's enough.
So made by Dr. Ushkow, second Dr. DeMace. All in favor? Thank you. Correspondence, we have an excusal from Dr. McHugh. Ellis is working on their electronic health record, and Dr. McHugh is in endless meetings today, for which I think as a committee we should send our sincere apologies. Hopefully he will make it out of those meetings. The CMAC and the SEMSCO met on 9/26 and 9/27. There was less business before the CMAC than there should have been. There were actually a couple of projects that are ongoing that were not distributed to the group ahead of time, which is a shame. But we will be debating them in January. The thing that medical standards spent the most time talking about was actually the BLS protocols, which should have been distributed to each of you. And if you have any specific comments, please make sure to bring them to me and to Don, so we can carry those forward in January, the next time we broach the discussion. The BLS protocols at this point are going to the Emergency Medical Services for Children Committee, as well as the State Trauma Advisory Committee for their input, and we'll see what else comes to bear from those. They will be a big transition in terms of the number of words on a page, but the actual medicine on those pages really hasn't changed very much. So hopefully they will be well accepted. Probably the single most notable thing that came from the CMAC and SEMSCO meetings is that Ms. Barnes, who has been our able captain at the Bureau of EMS, has announced her resignation effective 12/28 of this year. Lee will be retiring. She was wished well by both the REMAC, the CMAC and the SEMSCO. I certainly will miss having her there at the Bureau. In the fine situation that is civil service law in New York State, they cannot fill the position until the position is vacated. Therefore, there can be no overlap of the old and the new. So we won't have any idea as to who is going to take over that role until 2018. Somebody did note during academic committee that we think that Ms. Barnes actually was the interim director of the Bureau for somewhere around a year before she was officially appointed. So we'll see what happens. Anything else from people who were there? Carol, anything else that you? No?
Age of EMTs. Age of EMTs.
Yeah, you want to speak to that for a second, Beth? That was an interesting one.
There is going to be new regulation to drop the age in which you're eligible to take the EMT class from 18 to 17 years old, in order that it can become a vocational track for both these high schools, things like that. There was some opposition about it with the ability of children to handle what we see.
Yeah, that discussion was actually kind of interesting, and among the things someone said is that children wouldn't be able to handle what folks saw on 9/11. I think the answer that was so ably said is that actually nobody can handle what occurred on 9/11 or what just occurred in Las Vegas. That's not something that age prepares you for. There's nothing that can prepare you for something like that. Dr. Doynow has just returned to us. We were just speaking about the CMAC and the SEMSCO. We talked about the BLS protocols, talked about the resignation of Ms. Burns and the age of EMTs. Anything else that, anything that was particularly notable that you wanted to make sure was mentioned in this forum?
No, just that we, a number of us met with the commissioner, talking about the problems that currently exist with EMS and recruitment and keeping services from going under. And he asked to have another meeting with us in the near future, so I'm just waiting
The exciting thing actually about that meeting was the fact that it occurred.
Right, and the fact that he'd like to meet us again, so, he has interest in trying to resolve the issues.
I've been representing you on the CMAC for 14 years at this point, and in those 14 years, I have seen the commissioner several times. This is the first time for CMAC business that the commissioner is actually acutely engaged members of the State Emergency Medical Advisory Committee and the chair of the council, which is very exciting, very exciting. So hopefully we'll see some movement there.
Might just to back up, I just want to lend support with lowering the age of the EMT class. I
Please.
look back at my life, it is why I do what I do, both as an emergency physician and why I do what I do in the field and meetings. I think it's a wonderful, wonderful idea. I'd actually rather see it at 16.
Gotcha. Thank you. And frankly, I took my first advanced EMT course as a 17-year-old and started riding on the ambulance as soon as I turned 18, and then took the first EMT course I was eligible for. So I'll sort of fall into that same pathway. In both of our cases, our initial job is probably to saddle the horses up, to get them there, but the reality is that it worked out well. I think the idea of being able to use it as a vocational track in high schools is spectacular, absolutely spectacular. Tim, you want to talk a little bit about the HOC and the radio communications?
HOC met on Wednesday, September 20th. Scott Heller chaired the meeting. There were 2 talking points I added there. The big one was hospital radio communications. Everybody in the room had pretty much a common consensus that both hospital and field to hospital and vice versa need some type of improvement there. Nobody really had a suggestion as to how we could improve it, but I thought I threw it out to the group that maybe that could be an assignment to the REMAC Radio Committee. We resurrected that a couple of years ago. We met a couple times. We kind of dropped off the face there for a little while, but perhaps that could be, a task or assignment for that group to look into. Everybody there thought it was a good idea, so we'll see if that goes somewhere. And the only other thing they talked about was the Maccabi games. Had a great turnout. Lots of participants, lots of families from outside the region, lots of host families to put those people up. Number of injuries and stuff treated there, everything vastly minor stuff. They had something like 55 medical volunteers as well. So things went well in that regard. Those were basically the 2 big talking points at the hospital.
Tim, just one quick question. When all the agencies are going to 800, are the hospitals going to go to 800, or are they going to stay in the
I do not know. Does anybody here know? And it wasn't discussed there.
So the HEAR frequencies are here to stay. However, the concept of putting some of the now surplus 800 radios, once the changes are put in place, into the hospitals was actually something that was being moved forward by Deputy Chief Sini before he retired.
Okay.
It continues to be moved slowly downfield by a contingent out of the city of Albany in particular, that would hopefully put one 800 band radio in each hospital that could be impacted by the city of Albany. That can be a very broad swath of the capital district, if we are as liberal as possible with that. That would be the aim that group was taking. The HOC was taking a much more active role in it, so I'm a little surprised to hear the way it was presented today. But having some radio
Well, Lee
committee
wasn't
folks
there.
would make consent.
Lee Borman wasn't there
Okay.
either, so he
Gotcha.
probably could have talked a little bit more.
So I think
about
having Lee involved and having some active communications people involved would be huge. The former chair of our radio committee is playing golf in Florida right now, so we'll have to seek out a new chair for that committee. So if anybody is particularly interested in radio communications, please step forward and let Tim know. One piece of interest off the Maccabi games, just for everybody's information, the Hudson Mohawk Marathon is this weekend. It's actually Sunday, running from Schenectady into Albany. The most interesting component of that for me is the fact that it's actually going to be 80 degrees on Sunday, which would be very different weather than we have had for the last few marathons. So the potential is certainly there for some significant heat-related illnesses. Luckily, we will have the Hudson River to dunk people in at the finish line should they become too hot. I promise. We've got dunk tanks. All right, no BLS upgrades, one ALS upgrade, and we'll discuss it now rather than in new business. Mr. Gilmore's here from Mohawk Ambulance to speak to the upgrades for Capital District Ambulance and Physicians Ambulance, which are transfers of operating authority to Parkland.
Correct.
Did I speak correctly?
Correct.
Please.
So actually, the ambulance service is Parkland Ambulance. Mohawk Ambulance is a DBA of Parkland Ambulance. Everybody knows us as Mohawk, but the actual company name is Parkland. As of yesterday, the acquisition of Doctor's Ambulance and Capital District Ambulance was complete. So we will be running their vehicles now. In the past, Doctor's Ambulance, or I'm sorry, in the past, Capital District Ambulance was an ALS entity. Doctor's Ambulance was not an ALS entity. They never ran that ambulance as an ALS ambulance. As a company being run under Parkland Ambulance, it is our desire to be able to run any or all of our fleet at an ALS level. So we're asking, we put in a request to upgrade. Our intention and part of the purchase agreement is that we will actually always have a Doctor's Ambulance and a Capital Ambulance in our fleet. So we would like the opportunity to run those ambulances at an ALS level. Just so everybody here understands, we as employees are actually employees of Parkland Ambulance. And all of our, like our narcotics control plan and all of our ALS plans are actually under Parkland Ambulance. So that, so we're just looking to run the sweep of Parkland Ambulance to cover those two DBAs.
Just for my own interest, Dan, when you acquired Capital District and Doctors, both of them had significantly restricted operating certificates.
Mhm.
Have those merged in with?
No.
with-
Nope,
So it's only the city of Schenectady, city of Troy,
Correct.
city of Walton?
Yep, so with those particular units,
Mhm.
we do have a restricted service area. So it's a different company, but it's kind of the same situation with Schenectady Ambulance. Schenectady Ambulance and Parkland Ambulance, Mohawk Ambulance have two different certificates of operation that have us restricted to different areas.
Gotcha.
So our dispatchers will obviously have to be mindful of that when they utilize the fleet. But as far as resources go, we have 13 sets of ALS gear. We have 52 paramedics that work for us right now. And the staff, again, is just, you walk into the station and you get assigned your rig. So you don't always know what color you will be that day when you walk into work. We would just like the latitude to be able to use those vehicles equally. As far as equipping them as ALS, yes. As far as the certificates of operation, there are different licensures as far as where we can operate them. So,
Gotcha. We need a motion, I guess, before we have additional discussion with Dr. Bosco.
Is there a reason why you wouldn't just try to acquire, or in acquiring these two services, why wouldn't you just try to operate in everything under your primary certificate of operation?
because actually part of the acquisition was their operating certificates.
So you have to maintain those as a separate service?
Yes.
Okay. I don't,
You can't just put the piece of paper in a safe.
No, you have to.
You have to actually have it on the side of an ambulance. The ambulance actually has to be turning a wheel. Or you don't have the ability to
They
maintain
can
the
take away
operating
that
certificate.
certificate, make it in
Right. That's happened several times. Recently, one Rensselaer Volunteer Ambulance, for example, didn't turn a wheel for a year. Their operating certificate was revoked. Neil's had their operating certificate ultimately revoked because they hadn't responded to a call in a year. So, really what this is it's an administrative, it's a final administrative hurdle to Mohawk taking on these new entities.
and all of the people that are on those two new ambulance services will be employees of Parkland, correct? And they'll be under the same requirements as any of your other employees to maintain certifications, et cetera.
Yeah, the administration of those ambulances will be uniform across. Same medical director, same company policies.
I'll make the motion to approve what you're requesting.
Let's do it as two motions. Let's make a motion for the approval of ALS operating authority for doctors first, if that's right. Dr. Foster?
Fine.
Second, please. Seconded by Dr. Rathert. All in favor? Any opposed? And the same motion for doctors? Or no, capital district, sorry. Just make sure I get them both. Same motion for capital
So moved.
district, seconded by, this time Dr. Doynow. All in favor? Thank you. Any opposed?
One other topic.
Hmm.
On the BLS side, we have, I believe, all the advanced BLS modalities that are allowed in this region under Parkland Mohawk Ambulance. We would like to, the agencies that we required did not. So we would like to be able to, any of the BLS modalities, obviously defibrillator, but albuterol, aspirin, Narcan, and Epi. We would like to be able to do, again, the programs are under Parkland Ambulance. Everybody here knows it as Mohawk Ambulance, but the programs are under Parkland Ambulance. I guess our question is, do we really need to apply to this, this agency to do it? Okay.
Okay, just so, because the state actually weighed in on this the last time when you guys didn't upgrade and we had the two, and remember I sent you over the stuff to sign and get the stuff back for the ambulance. So the state does want one for every CON. They want the paperwork for every CON, so you have to do 4 sets of, you have to have 4 sets on file. It's exactly the same thing, you get to change the name and get 4 signatures. But the good news is you don't have to do EPI anymore because that's kind of been not decommissioned, but changed.
Deregularized.
So really the ones you need to do are albuterol, you need to do Narcan, and CPAP if you want to do BLS CPAP.
And check and inject epi if you wanna do check and inject, right, versus.
You don't have to do that because that's now a standard BLS.
Okay.
And glucometry is good.
Oh, yeah, glucometry, yeah.
Glucometry.
CPAP can be
But-
part of BLS rigs?
Yes.
But it's, and all of that does not require a vote.
Okay. We just need to fill out, we just need to fill
Yeah,
out
it's
paperwork.
just exactly like we
You
did
guys-
before.
You guys have it on file.
Okay.
Exactly.
Sorry, yes, is that-
That's it, thank you.
You're welcome. Sure there's nothing?
No.
For now.
We'll give you a minute, okay. And Dwaynesburg Ambulance is going to EPCRs, which is awesome.
So, actually,
Almost awesome?
they have been EPCR for a while,
Nearly.
actually, they just transitioned, a couple years ago, they transitioned to EMS charts. They are in the process of an agency renewal, and so the new thing that the state has added to the agency renewal is the EPCR agreement that the state has now taken over. So they are the first one in our region to actually do that, and that's how that got into the agenda. It's not really a new PCR thing, it's just a new document that the state is requiring all the agencies to do. So we all do our agency renewal every 2 years, you're gonna see that form as part of your renewal. It's gonna come through our office, we just put it out there by mistake, that's all.
Do me a favor. Please don't.
Don't,
Does anybody in here want to know when somebody actually renews something they're already doing?
right, so we're not,
Yeah.
it was just a
Just
mistake.
maintain it internally. Thank you, Dean.
That was my bad. I'll take
That's
credit
okay.
for that.
I don't think there's any bad on that. We've got some new pads out there, which is awesome. New business. The first thing I wanted to talk about is something coming from the Department of Health and from the governor's office directly, which is really exciting. And as you know, we've been handing out community access naloxone very liberally, including a very active program through REMO, reaching out there, talking to people, teaching the use of naloxone and handing out kits. When we do that, it's actually costing the citizens of the state of New York about $75 a kit, because that's the cost of the Narcan, the little blue bag, and the atomizers that are in that kit. Two things that are important. The first is that the state has made the decision that they're gonna move to the single-use nasal atomizer, the ADAPT product. Actually, Tim, you've got some in the back, right?
5 boxes of right over there.
Big box of
Let me
them
see
on
if
the
I
back.
have a demo back here.
Yeah.
Where Courtney hides them.
Thank you. Just so you can take a look at, but basically it's a little gizmo, you stick it in the nose and you push the plunger. It's that easy. The naloxone that comes out is 4 milligrams and 0.1 ml of diluent. That's the field trial that we've been doing locally with the ALS services, which has demonstrated that this is not a hazard to either patients or personnel, which is why they ultimately made the decision. The cost of that is actually exactly that same $75 or so. What the governor's office, working with the Department of Health, has done is they've actually made the decision that they will pay the copay for anybody that goes to a pharmacy with a prescription for naloxone, so that the copay naloxone will actually be free to that person. But to the state, it's going to be the cost of the copay, which is usually less than $50. So it gets rid of the accounting at the individual places that people might get naloxone otherwise, and is a significant savings to the state in terms of actual cost. While at first it seems like it's very liberal use of dollars, it actually is a cost-saving move. And it'll make it easier for people to get naloxone when they're getting multiple morphine equivalents, opioids with benzodiazepines, or have had a prior history of overdosing in the setting of chronic pain. So these are going to be, it's going to be a pretty big step for the state. It's called the NCAP program. There is more information available online. And for all of us practicing in emergency departments who might consider giving someone naloxone, this gives them the opportunity to get it at limited cost. If somebody has no insurance whatsoever, they can still get it through a community access program, as in Catholic Charities Project Safe Point, through many of our emergency departments, and through REMAC. So lots of different alternatives there. Actually, with Tim, if you could just pass a bunch of the new ones around, even open a couple of boxes.
Back there, that's what I was going to do.
Yeah, just so people can take a look at them. So it really is a cool little gizmo. The one thing that's really important if you guys are ever in a position to deploy this is don't prime it. You know, if you use a nasal spray, you always want to squirt it a couple of times to make sure it's coming out before you use it. With this stuff, if you prime it, it's done, because it's got one squirt in it. One squirt. You push it down, needle goes into a plunger, the plunger depresses, that's all the Narcan that there is in there. There's no more. So, any questions about NCAP?
Are they gonna be available to, like, I know you were giving them out to some of the first responders, is that what they're for now? Are you gonna be giving out to first responders?
So the goal will be that first responders will be switched to this over the course of the next year or so, as the current naloxone that they have expires.
So did they contact Tim?
So it'll be contacting whoever their contact is. So if somebody has been working through REMA for stocking of their naloxone, that's who they should contact. But they need to make sure that they get some training materials along the way. It's one of these things where we'll be switching law enforcement to it as well through that same cycle.
Thank you.
Okay.
Does this end the pizza study?
This effectively ends the pizza study. So for those of you that were actually looking for dinner as part of this, pizza study is now done, and the pizza study is done, letters should have gone out already.
And Courtney's out there right now cleaning that up.
Great, excellent. Yeah, so now, Kenny, you're gonna have to pay for your own pizza. Sorry. That pizza study, by the way, was a tremendous success. You know, it's a good have a joke of a name for it like that, and I think that's how I referred to it as well.
You did.
But the idea that people would actually complete study materials well, the cost of a pizza, ended up giving us a significant amount of information that was very, very, very valuable. So that was great. Dr. DeMace, you and I asked if we could put a quick conversation on here about a reinforcement of interfacility patient destination changes. Would you like to, in as non-specific a way, talk about that?
Are we referring to stroke?
No.
And
We're specifically talking about a case that you and I discussed about a redirection of the patient at the
Oh,
patient's
okay.
choice, that one.
Okay, so, and did this have to do with an attending DP, by any chance? On the other end? It was my case, correct, that I redirected?
That one would be fine. You can also talk about the other one that went to a hospital in Troy from your facility. We're being very, very vague because we're trying to be very, very
No, I
vague.
got you, I'm sorry, I thought we were talking about, okay. So there was a, I was informed, I was in the office one day, a couple of weeks ago, and we literally in 18 minutes received 7 ambulances at one time. And so obviously they're gonna line up, there wasn't a place to put those patients or put them into a gurney right away. But we were working our best to do that. I came out of the office to help with that and sort of see patients and start some mortars on them before they were put on gurneys. And there was a conversation between one of the staff members, from what I understand at St. Peter's, and a patient that basically said, "You're going to be waiting a long time before you get a stretcher." That's how I understand it. The patient then turned to the EMT or I'm not sure if they were paramedic or not, and basically said, "Take me to Samaritan." And so that's what happened. When they arrived at Samaritan, the EMS provider was obviously very upset, and they told the staff at Samaritan, and that's where it went. And I was told about it, and was very concerned about it in the light of EMTALA and so forth. So, and then we were able to have a little bit of diversion there with Memorial eventually, and within a half hour they got six other ambulances that would have come to St. Peter's actually. But we ended up getting 8 people in about 40 minutes, which happens. I mean, it happens from time to time. This was, pretty unfortunate that this actually did happen. By the time I heard about it, the patient was already out the door. So that's basically the story.
From my perspective, and, Sam, you can speak to this from an ASAP perspective potentially, but from my perspective, I think the most important thing is that we'll all face things like this. And the fact that we can pick up the phone and talk to each other will make the difference in assuring that while you may have had a very, very limited screening exam, we can preclude the anger-mediated EMTALA issues that otherwise might take place in a situation where really the patient made the choice to go somewhere else, but technically it already crossed your threshold. And we've got to make sure that that stays in place, because the ability to have conversations about these situations when there is no patient harm and it was the patient's choice is going to be the most important thing that we can ultimately do, I think. Sam?
I think in a situation like this, as a fail-safe for everybody involved, if EMS is still with the patient on the stretcher, and the patient is insisting on going to another facility because they don't want to wait, I think that the EMS provider should go to the charge nurse or any of the provider and tell them what's going on, so that at least a provider is aware of it, that's in the department, can come to the stretcher side, talk briefly with the patient, and be able to say, in no uncertain terms, "I have offered this patient evaluation, but they have insisted on leaving this facility to go to another facility." That really covers everybody involved.
Correct. And that didn't happen.
And they're really, even if there's not a medical screening exam, it's clear that if the patient's compos mentis, it's their decision to leave, and we are offering, wherever we is offering that medical screening exam. But to turn around and go out with the patient and not tell anybody about it is probably putting everybody at risk. So I think that might be the take-home message.
So I think the issue here, though, is that the EMS provider, the person who gave this advice, if you will, to the patient, was actually acting as the charge nurse temporarily, because our charge nurse was on break or in the bathroom or whatever, which is that happens. And So unfortunately, that
What,
charge
it
nurse,
wasn't the EMS provider's issue in this case, is what you're saying.
that's how that's, I mean, there's two sides to this, but
The charge
But that's
nurse
what I'm getting.
giving inappropriate advice is an internal
well,
issue.
you know, sometimes it's not that it's inappropriate, I think they were being realistic of that, it might be a little bit of a weight, but intonation is,
Yeah.
you know, it's like body language, right? It's the same
I think
thing.
the word an hour
You know,
was gonna be an hour week.
Was that what it was? Yeah, an hour.
Yeah, that's
So-
totally inappropriate.
Which didn't happen, we got people in probably all seven within, or I should say six, but one came in within probably half an hour. The department was full, I mean, it was, there's no question about it, 15 or 16 in the waiting room. And every bed in the back was, every stretcher in the back was taken, for the most part, so.
In my
But we
opinion,
worked
it
it
would have
out.
been incumbent upon that acting charge nurse to come and get a provider. at that
Correct.
point, You know, and
Right.
so, you know, that's an internal issue that
I agree.
Frank's gotta deal with.
I think I haven't seen you smile that much. I think this is something actually that, Tim, we need to make sure this becomes an item just for discussion at the next nurses committee meeting as well, so it can be passed on to them to continue to move forward. But I think the other thing that we shouldn't do would be to issue anything that specifically tells EMS what they need to do in that situation. Because I think there are a few things that could make people look more closely at transfer or move patterns. And I think we're better off with less people asking less questions. But the reality is that when there is no patient harm and there's good discussion and conversation as to what's going on. As soon as you know a patient has left your facility, making the call to say, hey, I just heard this patient's gone. By the way, they're on their way to you. This is all I know. I'm sorry. Is a really good step to do. So, Howard?
A few years back, I had a similar situation, and I ended up transporting a patient out of a hospital ER while they were on my stretcher, and went to a different hospital that wasn't at least under the same umbrella. And I ended up getting contacted by the Department of Health through my agency head, and there was a discussion, remediation discussion regarding turnover of care and when it happens. And I don't know if this body wants to look into it or not, but the description then was that once you had crossed a threshold and turned over a patient, EMS, unless you were in an operating territory where you could accept a new call, you had no jurisdiction to do an inter-facility transport, which is essentially what it had become once I had delivered a patient to the intended facility. So I wish Mary was here because she probably would have something to say.
I actually don't think that's true, because I think Article 30 says specifically, if you brought the patient into the ER, you can actually take that patient out of the
That is
ER,
right.
regardless of whether.
And if you,
I
I
it's not-
think
that
formally
wasn't an
turn the patient
inter-facility
over
transfer.
to a
agree.
ED staff member, a nurse or a provider at that point. I mean, you could argue that you didn't turn the patient over.
Completely
Right.
agree with what both of you were saying. And this was a little bit different too, as I was an ALS provider at the time, and this also got paired into questions of, can I provide continuing treatment while standing in an ER?
That's
So-
another issue.
Well, now you're actually entering into an area where we go all the way back to Mr. Ronsky, where the CMAC and the SEMSCO and the Bureau all were very, very clear in that what we should ask our EMS providers to do, and then protect them is making sure that they are doing the right thing for their patient. So that has already been very clearly elucidated on the record. And I think that's one of those situations where we have to be very careful what our regulators are regulating and whether or not they should be regulating all the time.
So when this question is asked of us as administrators from our field providers, the question of EMTALA always comes up, and I don't think most EMS providers really have an most physicians probably don't have a good understanding of EMTALA, but
We have to.
yeah, well, I say that jokingly because it's probably very convoluted and it's probably very big, broad set of regulations, but the answer probably that they're looking for is when does it actually kick in, and so I heard you mention threshold, and I think the idea is in most EMS providers' mind is probably at turnover and probably not at threshold. And so is the answer the threshold when the patient is in our care as opposed to when they walk in on their own?
I think,
Is it different?
I think the answer is what Dr. Bosco said.
Actually, if
It's
you
actually
read
the
the
property.
regulation,
It's
it says the
Oh,
property.
Way too many people talking.
So it's either the property,
Property.
or 100 yards, or 200 yards. It's entirely dependent upon which circuit court's opinion you're looking at for which specific case. But I think the most important take-home from it for any EMS provider is exactly what Dr. Bosco said, which is, if you get contacted as a supervisor that one of your ambulances is in a hospital, and the patient now wants to go somewhere else, get in touch with a charge nurse immediately, or a provider, or frankly, call a signal from the nurse's station, from the EMS desk, right? Which has been done many times before, including by some very sarcastic providers who are in this room. And I see many of them grinning right now. But call that signal, find that charge nurse, and let's make sure that we can tie this up with a bow to keep everybody out of trouble and make sure that the right thing happens for that patient.
Right.
Because the Emergency Medical Transportation and Labor Act was designed specifically to make sure that hospitals were doing the right thing and weren't basically cherry picking the patients that pay and telling the ones that won't pay to go somewhere else or sending them somewhere else. And in this case, where you've got a patient making the decision that they want to go somewhere else, we need to make sure that we're protecting the hospitals. So, anything else?
The other thing I wanted to bring up though, because this was what was on my mind was, in taking the REMO call, for a patient who was in one of the hill towns, West Lawn or Bern or something, I can't remember. Or it may have been further up,
No.
or it may have been Castle, I'm not really sure. But they were planning on coming to St. Peter's, but they're about 20 minutes out, 20 or 25 minutes out. No time of onset of stroke, rightward gaze with a dense left hemiparesis, and awake. So they called and said, we're about 20 minutes out, REMO call. And I said, I think the best chance for this person, because it sounds like a large vessel occlusion, would be Albany Medical Center. So keep in touch with me, I'm gonna give them a call. And I gave Albany Medical heads up, they said, absolutely. I got a call back from EMS, and they said, we're going to, thanks for calling, we gave them a heads up, we're gonna be heading in there, and it was seamless. I don't have a follow-up to that, I have to ask Dan, was that?
Yeah, it was Valatia.
Oh, okay.
I can tell you the
That's
follow-up.
right, it was Valatia, not.
Yeah, the follow-up was a positive outcome. It was a huge clot, and they went in
Perfect.
and got it. Yeah.
Good.
So it was 100% the right call, and I don't know the long-term outcome and how the patient made out after that, but the patient went in for a clot retrieval, and it was exactly what you thought.
The key to that phone call, I think, Frank, is you didn't say, I'm not taking the patient.
Correct.
You
I
said,
explicitly said, I'm not
let's
refusing.
let's redestination this patient
Right.
based on their disease process.
I was actually
Which
gonna
is
catch up
exactly
with you
what I
after,
did.
because I looked up the MD number on the chart on the REMO website to see who the doc was,
Right, right.
and I saw you
should
here, I
call
was gonna
back
catch up with you
afterwards,
afterwards.
right?
What's that?
You spoke with me again.
It wasn't me, actually, it
Oh,
was one of my guys, but the chart came through QI and I saw it, and, I think the other thing, quite frankly, just to pat, the provider on the back, the paramedic on the back, was a really thorough description of the patient's condition, because I think he painted a good enough picture that you knew what was going on as well, and, I think everything just worked the way it was supposed to.
Well, it sounds like a good case. Sounds like a really good case.
We've talked about that topic before at this body.
I think using the language like you guys are referring to, you may want to consider A, B, and C because of A, B, and C, but we are still happy to receive the patient. But you may want to discuss this with the patient that Hospital A may be a better choice in this particular clinical situation. I don't think that gets anybody into trouble, and you're acting on the best interest of the patient.
Being in a more remote hospital where this comes up very frequently, a lot of times I will say, I think, you'll get a definitive treatment with these other centers, but if you feel the patient is not stable enough to get there, you can stop here and we can then re-decide what's happening. That make sure they know that if they're not comfortable going up to Albany, just come to us and then we'll work it out.
Very reasonable.
I wanna make sure they realize that as well, that, you know, especially coming from outside, far out in Greene County and things like that, that if you're closer to us and you're not comfortable, we'll still take the patient.
Yeah, makes good sense. Okay.
I think, you know, we talked about this last month, this overstaffing, crowding issue. You know, it would be great for EMS providers to say, hey, look at, you know, and I don't know how we can do it, an app or something, but look at the hospital condition, and we're not like people in the rooms, but hey, listen, we're going to St. Peter's and you got a sinus infection and their condition yellow right now and their wait time is blank. Memorial across the street or Albany Med is condition green. It might benefit you to go there first. You know what I mean? And again, I don't know how we can roll it into the communications that we're missing some point, but just for us on the outside as a timely update to kind of say, look at, they just had 7 ambulances pulled in and they got an hour wait when you're coming in with something you really don't need to be at maybe the mothership for, maybe the Albany Med for, and this hospital's condition green, and advise the patient, look, before we even end up in that situation where we're 8 stacked up. You know, I don't, someone's gotta be able to come up with something portable that we can all see just to kind of figure out who's in trouble at that
Well,
minute.
there's a lot of different potential options for that. But the one missing piece for every single one of those options is a way to pay for it.
Right, that was it.
So
The apps we had here, the presentations.
Yep.
there's a bunch of different potential apps. Those, by the way, I'm still in need of somebody to formally chair the committee to continue looking at those. So if somebody's interested in doing that, please, let me know. But there are a lot of different options. Some staffed with people, some staffed with computers, some acquiring data. Some of this data is already in the public domain through the Department of Health. One way or the other, it'd be really nice to be able to coalesce that and give it as good information for our EMS providers
But
to
as
be able to talk about.
providers, I think that would be the biggest help to you guys, knowing that you guys are, you know, up to your eyeballs in patients, and somebody across town or down the road is, got 10 open beds.
Yep. Exactly. And I think we're gonna find this on a lot more situations as well. Right, we'll have some very specific patient care related issues, which will end up.
Road signs on the side of the road, or the roads coming in.
Well, Florida has it.
Yeah.
Florida has the wait times posted, you know,
Right up 95.
Yep.
Exactly, we're gonna post them in Albany too, they're gonna have, instead of clocks, they're gonna have calendars though. All right, we're still better off than a lot of places in the
Oh,
West.
yeah.
We need to remember that. Drug shortages. Guess what, folks, we don't need more 1 to 10,000 epinephrine. Great. We issued an advisory last week, Tim, 2 weeks ago, on 1 to 10,000 epinephrine, as well as sodium bicarb. So this is something that continues to be loudly on ACEP's agenda, access to emergency drugs. We've got to come up with an answer for this eventually, because it's ridiculous. Jeff?
You might want to check in on carpet jets for morphine as well. I heard very recently that they're going to be coming very limited supply. So check with your providers and see if that's the case, but that was the last update I had, and that was last week. So.
Gotcha.
IV Valium in the hospital is gone.
Mm-hmm.
And we just heard a bunch of stuff is gonna go in back order because I guess, some IV solutions, because Baxter makes a lot in Puerto Rico. So there's no power on 90% of the island.
I think there were 12 or 15 drug manufacturing company or facilities on
So
Puerto Rico.
it's just gonna get worse
Yeah.
very soon.
Very true.
Actually, I was in the information memo I got.
What?
One of our information.
Yep.
Fentanyl, I think was also.
Thanks.
Fentanyl's gonna be in short supply everywhere except on the street.
So what, more?
You got out of the corner, man.
Exactly.
I guess we're just using ketamine.
All right, let's look at the REMAC RSI letter that Dr. Ushkow was nice enough to formulate for us. Did everybody have a chance to look at it? Thought it was a fantastic start. The only thing that I think needed to be added to it from my perspective was just a reminder to our REMAC physicians, or REMO physicians, that every agency doesn't have paralytic medication. To add that language in, so that they're not asking an agency that doesn't have paralytic medications to try to use them. Anybody else have anything? Dr. Abbott?
Yeah, there's just a couple of points. Just the final sentence in it needs a little tweak, just basic verbiage. I think that and I appreciate you putting it together, it's actually very good. The little nitpicky stuff, just putting in quotes, the format, it was referenced twice, once in the subject, I think, and then once in the body that didn't have quotes. So just putting quotes around the format, just because I don't want them to think there was a like standard protocol. And then my only other question with kind of how this flows is specifically instead of one drug, one provider, to do, sedation only, intubation, or something like that. Otherwise, I think it flows just fine. If you want to reference on what I was talking.
So Nick, would you work with Bruce after this meeting's over to do it?
Well, just make the changes that go right ahead. I mean, I wrote the draft out, and that's just what it was, the draft.
Sure.
I was looking for input. Why don't you just make those changes, add what you might want, and you can just send it when ready.
Perfect.
And anyone else have anything to say? So I wanted it to
Yeah.
change it
Just
out
a
to everybody.
question, the letter's going out just to the REMO physicians.
Mm-hmm.
I think there'd be a benefit if we sent a letter to the agencies, because I can tell you that if it was sent to the agencies and we disseminated that amongst our paramedics, they wouldn't even call to begin with for it.
We should do as a CC, write it to the base station physicians, then you can CC the
Mhm.
agencies.
That's a great idea. That was good. Thank you.
Well, is this a prelude then for every ALS agency to go MFI? Is that basically what we're getting at by this letter? Is that?
No, the intent of the letter was to get people to intubate people in a proper fashion and not kind of go back to the old school ways. I think that there's a lot of discussion, and should pre-hospital people do intubations right now? So we can broach that topic. We just sort of said, if you're gonna do it right. As for should you or not, that's a different discussion.
Agree with Bruce. But Craig, did you want to broach that now?
Well, I think that's going to be, if it goes out to all the agencies, I think that's going to be some of their questions. Is if we're not going to intubate now using strong sedatives, and you have to have a paralytic and a second medic, I think we'll see a lot of, obviously intubations go away, which may not be a bad thing, or you're going to see a lot more agencies considering going into an MFI program. The law of unintended consequences, that's kind of, looking a step ahead is what I see from all this.
It's going to be an agency-driven decision from the medical director and the people, all based on their volume, and there's a lot of questions that have to be answered to do that.
I think the first thing that also, as Bruce is saying, this has got to be an agency-driven, volume-driven discussion. The first thing I think that would come up at this table, the first thing anybody would say is, all right, how many of these did you do last year? How many do you anticipate? And actually, most of the requests I've gotten for sedation-only intubations have come from agencies that actually have paralytics, but haven't gotten a second person on board and are making the request when they're basically pulling into the city of Albany, coming from far away. So that's my own anecdotal experience on this, and I think everybody's will be a little bit different. I think it'll be interesting to see what comes of this and the discussions that come up. Certainly, I think the idea of sending it out to the agencies that Jay makes is a fantastic one.
And for clarification, just because you have the paralytic in your box doesn't mean you actually have to use it. You can do it in a sequential fashion.
I would ask how many of us as physicians will do sedation only without giving them paralytic. And that's when we have the patient on a stretcher at an appropriate level with great lighting, backup tools, backup staff, and yet we still use the paralytic because we believe as physicians that that gives you the best chance of first pass success. And we're putting them in less than optimal conditions on a floor, in the dark, upside down, whatever. Then saying, yeah, go and do half. That was the reason that I brought this up last time, was I'm concerned that we are allowing practice that we wouldn't practice ourselves. And I don't think that that's a good idea. We, in theory, should have more intubations just because of the environment we practice in. We should have more than our paramedics do for the most part. Yet still we would go all or nothing essentially, and we're not giving them that same latitude.
Where we would have to do that change due to the protocol itself.
Right, and I understand it. I just wanted to, and that was the initial reason that I brought the question up, is because it sits funny, because everybody interprets it differently. And I didn't necessarily, we don't necessarily have to have immediate action on it. Maybe it takes more conversation. But it just seems problematic that is the current philosophy.
The current protocol doesn't give the EMS provider the option of using paramedic. Basically, the way it's written is essentially you choose one of your induction agencies and you administer
Yeah, you gotta use that paralytic.
And that was how I thought it was discussed.
It
when we
used to be
initially agreed
a
to it.
sequential.
Right, it was a sedatum, try it, if you
Yeah.
can get it without the paralytic, then give the,
Right.
That's not how it's written.
that's not written that way anymore.
I'm not gonna read it and think that my copy's gonna be different than.
No, I mean, basically, it says administer
The
power.
latest rendition.
Upload the app.
And I thought that's what we had initially decided. It says, administer an induction agent, either etomidate, or ketamine, if that's what you want. Administer paralytic, select one, sucks or
So,
rock. And then basically, then attempt to intubate. That's the way it's written.
so,
It doesn't say try intubation between, and at least that's how our EMS providers are interpreting it as well, just so.
what we do is a sequential RSI, and if we deviate from the protocol, we just notify Dr. Doyle that we deviated from the protocol. That's what we
And
do.
I say good job,
Yeah.
assuming it exists.
Assuming that was a good job.
Right. Well, starting with good job and then hearing the rest of whatever he's saying is probably a good way to go into it anyway. That's okay. Gio.
So the intent of the letter, John, just a quick, from a guy who works in two agencies, one that has RSI or MFI and one that does not. What's the intent of that letter then, to tell the base station physician not to give me something to assist that patient when I'm working for the agency that does not have the ability to do MFI? Aren't we kind of going backwards in a barbaric fashion there? I mean, don't we want to really kind of make things in the best interest of the patient? If I have to sedate them heavily to do, I hate to use the term poor man's RSI, but if I have to do something to intubate that patient, to manage them, really, isn't that in the best interest of the patient?
Well, potentially not.
To find the alternative? Well, then it's either every agency does MFI. Well, no, that is the answer. Every agency does MFI. Period.
I think that's what Craig was getting at,
Yeah.
is the ultimate answer going to be, you're either gonna be, it's almost like, you have to have capnography to intubate. We went there, which is fine, it makes sense, but, if you're either gonna be an RSI agency or you're not gonna intubate. That's where this is headed.
On the unresponsive cardiac arrest, you'll still potentially intubate them, depending upon a myriad of other things, right? But for the patient who's otherwise awake and, to some degree, GCS of
Understood.
7 to 8, I think there's a decision to be made. And I want the best first pass success rate.
That's what I'm getting at, is with the agencies that have not taken that step for whatever reason, I just look at that as being a disservice to the patient.
And I would suggest that has far-reaching implications, because what Gio's describing in the city of Albany, 10 minutes maybe away from Albany Med's front door, or back door, as the case may be, from, you know, getting the patient out of the house and in the ambulance and into the ER, maybe 10 minutes away, versus, I'll use Copake Rescue as the example, in the far reaches of Columbia County to Columbia Memorial's door might be even 35 or 40 minutes, or Rensselaerville's, well, we're an RSI agency in Albany County, so maybe that's not a great example, but Copake Rescue is not, and they're a long ways away from Columbia Memorial. You know, with that patient, with an unsecured airway, with a gag reflex, maybe they could successfully intubate that patient with some ketamine. You're effectively gonna tell the doctor not to give that order.
No, I think it's different than that, Scott, and I think it's important. This body has always maintained that you actually need 2 paramedics in order to intubate using paralytic medications. We've always been very, very set on that. In fact, there were some long discussions on that when it comes to, when it came to the protocols, and, because originally in the protocols it used to say you need 2 paramedics. Part of that commitment to making that decision to take away someone's airway has to be that there's somebody else there to say no. Right? That's the reason, one of the big reasons for that second paramedic. If you're coming from far away with nobody to meet you, right, because you work in an agency where there's only 1 paramedic, you don't have that as an option anyway, right? If you call and you talk to a doctor and you get Dr. Stanger on the phone, Dr. Stanger's just read this letter. Dr. Stanger should read the letter and say, all right, I can still order this, but I need to think about it a little bit more first. So how far out are you? And the answer is 15 minutes. All right, think about 15 minutes. 15 minutes means you're gonna draw it up, you're still driving, you're gonna try to intubate, and you're gonna pass that tube when you're crossing into the city of Hudson. So if that is all gonna occur on that, and that's the time frame that you're working on, it probably makes more sense for Dr. Stanger just to be ready to intubate that patient when he comes in the door.
Okay.
On the other hand, if they call Dr. Stanger and say, listen, I'm upstairs in the house in the village of Copake. We can't get this guy out of here without putting a tube in him. We need to carry him down 3 flights of stairs. Gives Dr. Stanger the opportunity to assist with the decision making to make sure it's being done as safely as possible. Gio.
I'm sorry, I gotta completely disagree with you, because I don't care if I am at the bottom of Myrtle Avenue, across the street from your hospital. If that patient needs to be intubated, the whole reason that we push so hard to increase our paramedics' accountability and have them treat the patient on the scene appropriately, doing that damage, whether it's 10 minutes, which is legit, even from the bottom of Myrtle Avenue, by the time you get them down into the ambulance, loaded up in there, through your doors, and then figure out where to find a doctor to do that stuff, is in excess of 10 minutes. For that patient to be hypoxic and not treated for that amount of time is just wrong.
There are
Patient
other
needs to be
options.
intubated.
There are other options besides intubating.
Well, I totally understood.
And we
Totally
should need
understood.
the REMO doctor needs to consider those first. If it's gonna be even Copake, I would recommend maybe using an LMA, and you can sedate them with an LMA. You're not taking away their gag reflex. You can use CPAP. There are so many other options. This jumping to intubating is, I don't think, the right thing. I think you need that great pause before you take an airway in the field.
But,
And especially in CPR, cardiac arrest, there's no place for intubation. You're stopping compressions for way too long, and every study is showing that.
Well, we don't stop compressions.
we don't
for
stop
the
compressions for
All
that,
right.
Doc.
And then, are you getting that tube in though?
Yeah,
With
yes,
it?
of
Okay.
course.
A couple I've gotten in my hospital don't.
And there's a whole wide variance of providers, but that was painting with an awful broad brush there, Doc. I'm sorry, but
Okay, well.
there are some very talented providers.
I'm not saying there aren't, but I'm saying in the heat of the moment, there's a lot more that goes on. People, I have seen, at least down in my neck of the woods, a lot of people, I'm sorry?
I didn't know who you are.
I'm Mike Weisberg from Columbia Memorial. So,
Not just from Columbia Memorial.
and I run Copake and I run NDP.
And you're the director of Columbia Memorial ER.
Yeah,
They don't know.
No.
I'm the chief of Columbia Memorial ER,
Yeah, yeah,
so.
yeah.
So we're spiraling away from actually the letters.
Yeah.
As we're getting into a huge discussion where really the letter just simply says, here, read the MFI protocol and make the decisions. And part that was pulled in, as I recall, was the decision is still in your hands. Just
discussion was just that it seemed like it was discouraging it. And
But I don't know if
That's
that's the
not
wrong
the
answer.
back one.
And if I am on Myrtle Avenue standing next to you, there's a decent chance that I'm gonna say, we're gonna put a oral or nasal airway in, DVM them, and we're gonna head up that hill, and I'm not even intubating them.
totally fine, but you and I both know that there are exceptions to those rules. There's circumstances that prevent that from happening in that timeliness of a fashion that can certainly be detrimental to the patient's outcome.
I'm sorry that he stepped out, I just wanted this REMAC to clarify something. You are not going to support LMAs on sedated patients, correct?
Amazing unsafe patients or something?
Right.
Yeah, I would put it in.
Yeah,
You can't put an element
in the EMS, in the pre-hospital environment, they
Correct.
don't see
Okay.
well enough to make me feel real comfortable about that.
Also, an unsedated patient is gonna be incredible.
Correct.
Gag.
Right,
You're
right,
gonna vomit
right.
right around there. I mean, you can't do that.
Yeah, the two of us kind of perked up when you made that statement, we were kind of.
Matt?
So if we could gotta go either which way, we wouldn't really need a REMAC. So at some point, we simply have to make a decision as a group as to how we approach the patient who needs ventilation. And to be clear, what we're out to establish is not intubation or securing an airway, it's ventilation. Intubation is to facilitate ventilation, and for no other reason really. I mean, there's a little more to it obviously, but not much. So if we've gone through the other things, even if it's in our head, of other ways to ventilate a patient, and we've come to a conclusion that the only reasonable way to do so is to put plastic tube into that airway, we just simply have to decide how do we optimize it, to your point, so that we're doing the best thing as often as possible for a patient. There's no such thing as a protocol that will address every single patient in every scenario.
Correct.
That's why you make a protocol and you stick to it, because you're gonna do as best you can with a protocol for as many patients as possible. So the anecdotal cases are not how we make the decisions. So let's think about the best way, come to that conclusion, be clear so that everybody's clear about it. Don't hem and haw and say, but kind of, sort of, not really. And then let's move forward, because until we do that, I'm not sure what we're doing is what the REMAC is supposed to do.
And the real population of patients that we're talking about here are the people that are still alive, in extremis, that the adjunct interventions are not helping. You know, you got the patient on BiPAP already. You've done whatever you can do with your medications, and the patient's still desaturating, they're still going down the tubes. And when you go back 20, 30 years ago, how many patients that were out in the field in extremis would come through the door and just arrested? And because we didn't have the proper tools for the medics in the field to be able to get that airway in safely. You know, and if they had been intubated prior to getting to the department, they wouldn't have arrested. So I think you're absolutely right, and I think we should be thinking about what's the optimal tools to give to our medics in the field to be able to intervene on a patient who's in extremis and needs an airway. And if MFI and all, should we be mandating that MFI be available for all ALS agencies at some point? I mean, that's the question. And that's not the question that...
It doesn't matter if you're 5 minutes or 55 minutes.
It's not the question that
Right.
we're dealing with this letter with Bruce, but it's a point that probably ought to be brought back for discussion at maybe in the academic committee down the road or something.
Well, I think it's one that also needs some data, right? Because we really need to know how many patients are ultimately getting intubated right after their arrival. And the hard part is, are they being intubated right after their arrival because they couldn't have their airway optimized, or because we need to have them intubated in order to perform a bunch of tests? Because laying them flat on their back and putting them through a CT scanner, where otherwise if you lay them on their side, you'd be able to manage that airway just fine, is an important decision point in many of our practices. So that's something else that needs to be taken into account.
Well, and also the non invasive ventilation techniques that we have today have saved a lot of intubations. Let's face it. You know,
I think they're
and
hugely underutilized in the pre-hospital field.
I agree with you.
Hugely.
I agree with you. And
I
I mean,
can tell you that where I practiced previously, we had a much more aggressive group of EMS, a more aggressive group of EMS providers for CPAP. Not about anything else, I'm not trying to quantify one, but for CPAP, they were quick to put it on, and they turned a bunch of patients around that previously would have been intubated, and I never, again, my wife hates when I use the word never, but I rarely see it happen here that we have early CPAP.
well, I think a lot of our EMS agencies, the ones that deliver to us on a regular basis, I don't want to name names, you guys know who comes to us all the time. I mean, I think they are fairly.
It's utilized.
Yeah, it's utilized fairly frequently in our practice, but.
And down in our practice as well.
I spend a lot of money buying them every month, so somebody's using them.
So do I.
These are two separate issues too.
Yes.
One is the, let's all agree, intubation, this point in the very early phase of any scenario, is not something that has to be done a lot. We'll just say it's not done, it doesn't need to be done a lot. Leave it at that. But there are two issues. One is the appropriateness of intubation and the things done prior to intubation. And the second is, when the decision to intubate is made, how do we approach that process? How do we approach that procedure with RSI or otherwise? Let's not confuse the two. So if we're going to intubate a patient, we should do it like this. That's one issue. And the second is, who the heck are we intubating? But we have to keep them separate, and that's what the REMAC's for. Let's talk about the first one, and let's talk about the second one. Let's put it as clear as possible on paper, and let's tell everybody to do that. That's what the protocol has to be. And I think there's enough conflating of the ideas and hemming and hawing about how we actually go about RSI or intubation that we're not actually giving clear direction. If nothing else, we should give clear direction. If we're wrong, at least we're giving clear direction, but let's try to give it right, and let's try to give it clearly.
Good thought. So I would suggest that we keep this open as a topic of conversation for December. Half of what Matt just said, which is the do we give everybody MFI? I think that part needs to be discussed.
Agencies, you mean, Mike?
What was that?
You mean agencies, all the agencies? Is that what you're saying?
Yeah.
You said, do we give it?
I think that needs to be a discussion. But the piece that goes well along with that is the who do we intubate? Because we need to be able to give that discussion as well. But I'd just like people to think about that so we can bring it back. And let's also think about what we should be looking at in terms of current data that we have regionally and that we might be able to acquire, and literature that's out there that some of us are pretty facile on and some that may need to do some more reading. But let's take a look at the literature out there on pre-hospital intubation and outcomes and how it changes, because I think that needs to enter into this discussion as well. Ken?
Just, is that something that can be, through the QI committee, taken out of how many patients were intubated, how many patients, what medications were used to intubate these people? And, I mean, obviously your cardiac arrests where there was no medicine used to facilitate that, but outside of that set of people, to look at what was used, how much was used, to get an idea, because, I mean, I'm sitting here going, geez, out of the last ones we've done, you know, was it a full, just, you know, give a little bit to help the procedure, was it this? I don't think we have any data on that yet, do we, to say, what's the norm?
Didn't you draw that data up and take it to Aaron's a couple months ago? You brought forth that, what sounds like that data to Aaron's.
What's most of the people doing most of the time, and what's working?
I think this is exactly.
What was that, Beth?
Dean will talk.
Aaron's requested that we do, we would pull our data to provide them with the number of MFI and how often it's happening and stuff like that. And so to pull data that includes all patients that were RSI, MFI, whichever you want to call it, is difficult because of the way we chart. Some people type in, gave etomidate, gave whatever, gave rocks, gave sucks, and they don't use the drop-down menu. And so to know exactly how many people are actually RSI, MFI, is hard to extract from all of the intubations. So the hard numbers are not as easily to come by.
They may not be totally accurate, but you're gonna have a basis of information. You can at least pull down whoever checked the drop-down box to say, look, here's what we used, here's what we did. There will be that information.
Well, I think it highlights two things that I think are really important that Dean just said. All right, we have said at this body an awful lot that if you're going to administer medications, you must use the pull-down menus. If we find people that are not using the pull-down menus for administration of medications, that needs to be an immediate letter to the medical director and to the ALS coordinator at that agency saying that they're not in compliance with what is appropriate for charting in this region. And that's absolutely adamant, because otherwise we can't track any of these medications. And it's profoundly important for any changes that we make to protocols and being able to review our patient care that occurs. The second thing that I think is important is it's really tough. I can certainly see why it'd be so hard, because I've tried to do this too, looking at who's getting what for which procedure, because it doesn't say what order it happened in. If you put a tube in somebody that's obtunded, and then you have to sedate them, it'll look the exact same as somebody that you needed to give the drugs to if you're doing a sort. But at that point, you've got a more concrete set of numbers. Dr. Miles.
So, I'm all for the data gathering. I think it's very important, but to be clear, the data gathering is to help decide what we're doing and if there's a problem with what we're doing. I don't want to confuse that with developing a clear protocol in the first place, because that's not driven by the data from our own territory. That's from having a REMAC and expertise around this subject matter in the first place. So we should have a clear protocol independent of any data gathering we do, and that doesn't require any time. So we should just be clear about the protocol. And the last thing is that a clear protocol will then inform what people do. And it's a little unfair to judge them on what they're doing if we haven't been clear about a protocol in the first place.
Well, let's stop for 1 second though. We have a clear protocol.
Fair enough.
Right.
We just have to communicate that.
What we need to communicate is the first half of what you said is when. Because the when is never part of the protocol. And the when is what's missing. Don.
The only thing that I would say too is just, we need to be really careful. We've had really good success rates with our RSIs or MFIs because we've been very selective as to who we let do it. And just giving everybody, here are the drugs, go do it, our numbers and our patient outcomes are not going to be looking that good. And we're well above what the national average, if you look at the intubation studies in the field, and outcomes look like, we just don't look like that at all. And that's because we have been so selective on who we've let do this. So just be careful moving that road.
I think that the unfortunate thing is, while we look at our success rates of putting the tube in, the hard part is actually getting the backside of that, which is the outcomes of those patients. And then deciding whether or not that airway intervention actually made a difference in the outcome for that patient is extraordinarily hard to extract. That's something that even the small numbers of patients that we take care of in this region will never be able to get statistical validity to be able to really decide whether or not that intervention made a difference for that patient's outcome. On a case-by-case basis, we can always make the case that it did, but it'll be more difficult to do that.
Okay. One more part of that would be just making everybody MFI doesn't solve the problem of having a PSI, procedural sedation intubation, would be, that's not the end all, because you still need 2 medics. So if you don't have a medic in your area, or if you're alone, or if you're heading down I-90 and something happens and you need to do this, the sedation intubation, that's your only option. If you take that away, then we have no option. You can still be
Nasal intubation.
Nasal intubation.
Nasal intubation. I've been listening to all this discussion, and I know I'm not one of the MDs, but I have to say I wholeheartedly agree with this letter. I mean, as a former flight medic with 2 other flight medics in the room, I can't even tell you how many times that we've landed to clean up a poor man's RSI. I hate that term on top of it. It's not good medicine. It's not good for the patient. For every one of these that you can say is success, I bet you I can come up with 2 that was not. They're called laryngeal trauma, aspiration pneumonia when the patient vomited. It's just not a good practice. And I don't think it should be allowed. I've said this to Mike for years. That's my take.
I'm just gonna go a step further and just say, RSA was not invented to make it easy for an anesthesiologist in. It was developed because it optimizes securing an airway. So if that's what optimizes secure an airway is, what's the big discussion about, to your point, Kevin? I just don't think we should be allowed paramedics to do sedation or intubation, whatever term you want to get to. I just don't think it's a good practice.
And I think what Bruce's letter does, to bring it full circle, is just to say, when somebody calls you saying that they want to do that, talk it through. Think about it. Is this really the right thing for this patient at this time? If it is, okay. If it's not, get set up wherever they're going.
And
That's what we're
letter
gonna do.
does, it goes with the protocol, and it makes, as you all know, we really don't, maybe the people in this room look at the protocol, but most base station physicians don't. So it sort of forces them to get a look at that. And it's not a giant book, it's just the one page.
Should you be including the protocol with it when you mail it?
Yeah, that's part of it. Refer to the protocol, read through it.
When I sent it out, I included the protocols with it, just in case somebody wanted to take a look at it.
What protocol exactly are you sending with this letter?
Every single protocol.
Okay, fair enough, but.
With particular attention
This is a fair
paid to
question.
pages 71 and 72, which
Well, that's,
discusses
I mean, the question is, because the RSI protocol does not allow for procedural sedation intubation or medication facilitated intubation.
Right.
So, the protocol as it's written doesn't even allow for this, period. So, which protocol are you sending? Are you sending the procedural sedation protocol, or are you sending the RSI protocol?
RSI protocol.
Okay, so why, is the question, because the RSI protocol should only apply to RSI agencies as it stands. And so, should you be sending the procedural sedation protocol?
Just to the letter with reference to RSI. That's why I sent both protocols, actually the whole complete protocols, but particular attention paid to RSI because that's the way that just the letter.
Okay, understood, but I'm just suggesting that
I think
the
Scott makes a good
RSI
case.
protocol, the way it's
Yeah.
written.
This letter applies really to the sedation protocol, so we'll make sure that one's attached to
Throw a
it. That would be the
procedural
right thing to do. Howard, what were you?
Okay, thank you.
That's the only one that would apply to.
They're in there.
Right, I'm just suggesting it's really pointing to the procedural sedation protocol, not the RSI protocol.
I don't know how
Howard?
this body wants to deal with this at this point in time. In the past, something like this would have been kicked back to the academic committee with a group to be formed, task force, whatever you want to call it, to present. And then the academic committee would choose from volunteers to put something together and bring it forth. Currently, it sounds like if we're talking about protocols, this is going to need to go back through a collaborative protocol process.
I don't think we're talking about protocols. I think Matt was misspeaking. Matt's real intention was prior to the protocol. Who should be intubated? What situation? Not rewriting the protocol as it stands.
And I think if we're gonna look at that, we really need to look at both national and statewide numbers and scope, and we need to look at a lot of different avenues and not make a, hey, let's figure this out by December or January, because all we're gonna do is continue to make decisions, whichever group is in the room agrees on, whatever group isn't, doesn't, and then we're gonna revisit this numerous times. I think if we're gonna do this, we need to form a committee of providers, educators, and physicians and actually move forward from there.
Sounds like a great idea. I think we found a chair.
So, what are we getting, what are we researching? I'm not sure what the question is.
Well, you know, there's numerous questions that have been posed, and I guess the question, if I were to sit on the committee, would be, what does this REMAC want looked at in order to go forward? Because just sitting here today, I think there's probably 4 or 5 at least different opinions as far as who should, when they should, who should be allowed to, what patients, under what protocol. We're talking about airway management, not just intubation itself, and it's kind of grown from there. So I think it would be interesting to look at not just data mining, but what's in a standard national education guideline, what's in a state guideline, who's doing what. Because I personally get worried when people start saying things, well, there should be volume to certain things. Because I can't wait to get rid of calcium chloride. 20-something years, I've given it once, and they died.
Yeah, no, I don't.
So I think this group in this fashion is not going to make forward progression unless we sit down and actually go and get a charge per committee to go and look into something.
I'd counter that by simply saying that this is arguably one of the oldest questions in emergency services. Airway management is not a new or sort of unsettled kind of science at this point. There is absolutely consensus around how to do this well. We don't need to data mine to determine that. That's what the REMAC exists for. It's why the expertise in this room exists, is to say, this is how it's done, and let's do it like that. I'd like to hear other people's thoughts on that, but I worry that we're gonna go out gathering data to sort out, as if this has never been asked before, about how you go manage airways.
My argument on that would only simply be that we are just one region of a multiple region.
No, we're one region with access to the same information that the rest of the world has, and the expertise in the room has been trained all over the country. We are representing this region, we should set the tone for this region, but we're not informed strictly by this region by any means. So we have the information we need to make those decisions already. I'd just like to hear what other people have to think.
Dr. Daly, maybe you can speak to a collaborative angle on this. Is this region able to make changes to its own protocol without going back to a collaborative protocol?
No.
That's what I was getting at.
No, we cannot make changes to the protocol itself, but how the protocol is interpreted for both cases of sedation managed airways, which is what this is, and the specifics to what the RSI protocol said, and how that is interpreted is gonna be at a medical director basis, right? So Don, for example, and frankly I, am perfectly happy with somebody doing a graduated management of that airway rather than going straight to paralytics. If you go in, intubate, that's fine. And that's because we're going dots. And if you remember, we created the dots rather than the numbers because it's not a you must, right? So I think that the question that we've really come to, and this is interesting because we have so many different perspectives around the table, is what we really have is a question of what is the map of airway management in this region? Not only what should we be doing in terms of intubation, but what are people doing otherwise? I mean, Dr. Weisberg was talking about using LMAs. I didn't know there was another agency around here other than Air Methods that was using their LMAs in the field.
NDP has, it's not LMA, it's the other one. No, not King.
The iGel?
The iGel.
So if your guys are using the iGel down there, that's something that would be good for us to know as a map of the region, so we can have a better idea and learn from their experiences.
And I meant to say
There will be
iGel,
times where
not
the iGel
LMA. I
is used.
misspoke.
And I think there's a lot of different information out there that even though we've shared information here on a regular basis, there's more learning to do. I agree with Howard. I think this would be a good one to go back to academic with so we can get that map. And I think the thing that we really need to start with is an airway management group through the academic committee, tasked as Howard suggests, with some educators, some providers, and some physicians to look at who are we intubating, what circumstances are we intubating those patients in, what agents are we using, what tools are we using for backup right across the region. We need to know these things. And this body needs to know it on a more in-depth basis. I don't think it changes the need to send out the sedation facilitated intubation letter that Dr. Ushkow has formulated with Dr. Rather in order to make sure that our physicians are providing optimal advice to our providers.
You don't feel that this letter conflicts the current protocol?
No.
I wouldn't send that until we get this
No, I
out
don't
a little
think
bit more. Just put that aside for now.
That's fine.
Get more answers and fill it out if you want.
That's fine.
And quite frankly, the procedural sedation, and the key point basically says, this protocol may only be used for intubation upon medical control order.
Right.
So you gotta talk to a doc anyway before you end up.
Well, but that conversation with the doctor is what this letter pertains to,
Right.
right? And that's why actually Scott was right with the don't send out the RSI protocol, send out the procedural sedation protocol, which makes a ton of sense. All right, all that aside,
To be fair to the agencies though, about the data and the directive was that they had to be electronic charted, not that they had to use the drop down. It was not as specific as we had discussed. So
then
that's
let's
why.
fix it.
It should be.
Fix it. Because any medical directors that are working with agencies that aren't doing it that way are not optimizing their workflow. And that's something that absolutely needs to be there. Because as I look at more and more things done on a national basis, we will be left by the wayside if we don't have our data where it's accessible. That needs to be fixed.
That's certainly reasonable data that the MAC can require of any RSI agency.
Would be required of any controlled substance agency.
Fair enough.
So perhaps a REMAC advisory to the agencies.
What I would rather do, because the agencies should be doing that already, is if we can find out which ones they are, rather than sending out an advisory that says, hey, there's a whole lot of people that aren't doing this right. Let's see if we can track down which agencies may need some education. All right, rather than painting with that broad a brush. I don't want to do that. It's not polite. Yeah.
Under the procedural sedation protocol, if you're looking at this, and you're coming down to the paramedic line, and you go, okay, I got my options, it's not way down to the key points at the bottom before it finally states, this protocol may only be used upon medical control for intubation. So I think somewhere at the top of this, it needs to say, for non-intubation, or something to say that it's not to be used for intubation, because it's under our standing orders, and it's not to the very bottom where it says, oh, you can't really use this for intubation. You know?
Well, fair enough.
In terms of considering a change in the structure, that's certainly something we can consider as we move forward collaboratively.
That's the
Right?
point I'm making.
That's just where that is. And those key points have got a lot of very key information on every single one of those protocols, not just
Right.
this one.
No, what I'm
That's
saying,
why
like-
they're called
Key. If they don't know
key
the key
points.
points in the protocol, then
Right.
maybe they shouldn't be claims.
All right, I think we have effectively beaten this to death.
Points of the protocol, maybe they should complain.
Do you mind if we move on? Although I will let Scott quote Jeff one more time.
No, Jay didn't hear it, I was just letting him know
We
what
gotta
Jeff
get this
said.
into the minutes.
It needs to be in the minutes. All right, with all of that, does everybody have their copy of the bylaws? The only problem I have is my red line copy is written in black and white. So I'm gonna do as well as I can.
I almost took a rip to that, circled it, but I figured it's a different shade.
Just do me a favor. Can you follow along with me and make sure I don't miss any?
Go get some.
Okay. So as we go, what I'm gonna do is go through each one of these and ask for a verbal agreement as we go. And then we'll move on to each one. If there's discussion at any point, we'll stop, and then we'll do a vote at the end. Does that seem reasonable? Yes, okay, good. Starting out, we go down to voting members 2.1, increasing the number of voting members to 18. Okay?
Do you want us to vote on each one of those? or-
No, just agreement is enough. Nods. If I see any, then we'll talk. Is that okay?
Well, we discussed all these last night.
Yes, and that's why we're just in agreement. Okay. Addition of the language AKA Regional Medical Director in 2.1.2, and correction of the language in the second line of that. Yes. At-large physicians increased to 8. Associate members, chair or designee from the Regional Nurses Committee. Representative from an ALS service. A correction of the number of counties that we actually have in the Remo region, which left us all very embarrassed. Term of office for associate members, 2 years, not 3. The chair shall be elected by the voting members of the REMAC. The chair should be elected from the voting and alternate physician members of the REMAC. Same language in 3.2.1 for the vice chair. Thank you. 3.4, elections will be held prior to the last scheduled meeting of the year. Nominations will be accepted, elections will be held prior to the last scheduled meeting. Nominations will be accepted electronically prior to the meeting and may also come from the floor as long as the nominee is present and concurs.
I'm a little confused on that before the last meeting. Does that mean it has to be,
Held prior to the last meeting, last scheduled meeting. Now, that's a problem,
no, because that's,
because that would mean we'd have to have elections right now.
how about we change that to elections will be held the last scheduled meeting of the year?
That's what it said before. How about if instead we say prior to or at the last scheduled meeting?
I don't know if that opens it up. You could have elections 1 month into the year. You probably should pick specific.
And
About
also,
during
since
the
you're
last
not
scheduled
voting on
meeting.
each change, it means the entire set of changes have to go back for 30 days.
No, hang on a second. Here we go. Should we have a vote right now on all the changes accepted so far? Thank you, Beth. All in favor? Any opposed? Thank you, Beth. Sergeant at Arms, that work. Appreciate it.
Pardon me, third.
All right.
How about by December 31st?
Elections will be held by December 31st?
That'll be the question.
Hmm?
Do they have to be held at a meeting?
At a meeting.
What months do we meet again?
December.
December's our next.
December, at the December meeting.
At the last scheduled meeting.
Going forward, it's not gonna be a major issue. It's
Just this one.
meeting right now that
Right.
we're worried about. So the reality is you could put just an exception for this time, getting started, putting it in for December, and then leave your verbiage in for all subsequent years.
Because you can vote to suspend the bylaws for specific problems like this.
Mm-hmm. All right, parliamentarian, what do we do? Do we leave it the way it is? Or do we add in, will be held December 2017 and prior to the last scheduled meeting in subsequent years?
I think you have to put some time limit, maybe use the word penultimate, in other words, meeting before that. Because if we go back to our last discussion, the whole reason for not having it just be the last meeting is you wanted to allow for an overlap of the incoming and the outgoing.
Mm-hmm.
So if we just make it the last meeting and then have it, then activate it the next year, you're not gonna have the overlap that we talked about. So you really want your elections the penultimate meeting, and then we can make an exception for this year.
Seems like September, October is about the right time frame to do it, then you've got the rest of the year to sort out the transition.
And when you speak of year, you're
What
also,
language?
is it the calendar year? Is it our fiscal year of this organization associated with the grant and all that?
Read the
So
language
the
as
year
it
has
is
to be
again.
defined.
The language as it is, elections will be held prior to the last scheduled meeting. Nominations will be accepted electronically prior to the meeting, and may also come from the floor as long as the nominee is present and concurs.
Well, that's not actually saying it will occur the immediate prior meeting. It's saying it will occur before the last meeting, so that's even leaving it more open-ended the way it's written. It's not, it's less definitive than it should be, even as it's written.
If I can offer just a suggestion, if you've got that pushed out to the group for 30 days already, it would probably be worthwhile passing that, just so you can vote and elect people, and then entertaining a bylaw change the first meeting of next year.
That's a great idea. Then you get around to all of it. That's a great idea.
But then we'll have to have elections then, today.
Or vote to suspend the bylaws and start it next year.
I guess we could do that.
Just note the exception for 2017.
If we suspend the bylaws, under what do we elect somebody from.
I think we're complicating it. I mean, we can make
Yeah.
an exception for this year,
Yeah.
given the time of year.
Mhm.
Just resolve that we're making an exception because of when we're doing it.
Because just because these need to, how exactly did we write the?
Okay, here's the other question. What do the current bylaws say, not the proposed bylaws? Because you could choose to not enact this clause and go back to whatever the current bylaws say.
Or you could do the election before the adoption of these bylaws. And then these bylaws go into effect January 1, 2018.
Well,
If
even
we
if
do
accept
that,
it now,
we lose
we
the
can make
ability
it
to have
happen.
candidates for elected office from our alternates.
We can vote on the bylaws now and make them effective January first, whether we voted on them today, tomorrow, next month, whatever. The timing of our vote on these bylaws doesn't change what we do right now. Well, it just, unless we said they're active today, and as of tomorrow, we're acting on them, and we missed the date, we don't need to do that.
But the problem is if we do that, we lose the ability to have those alternates vote as well.
So
Because they
let's-
were not a part of the original.
Right, so let's just enact it and say we're making an exception for this year, because we're enacting in this year of 2017.
I think that's fine.
So elections will be held prior to the last scheduled meeting, except in 2017.
Or you could say, yes, that works. You say, let's say we're generally gonna say September, October, and say, alternatively, in the meeting following the adoption of these bylaws, on
What-
XYZ date. So we adopt them on the 4th. We'll do them at the next meeting, which is the meeting after the 4th for this year, but routinely it'll be September, October.
Well, you don't want to specifically say a month, I would just say the second to
Right,
last
sure.
meeting of the
Whatever.
year.
I think
Because
it
if
would
you,
just be wise if we characterize it to fall in like September, October, however you say it, such that there's enough time left to overlap.
if the committee wanted to have a meeting in November or change the current schedule, you don't want to have the language say it's got to be in September or October. I just say the meeting prior to the final meeting of the calendar year. Just say that.
You don't even have to lock it into one meeting, you can say in a meeting in the second half of the year. Leave it wide open. And we'll aim for September, October.
So current suggestion is elections will be held prior to the last scheduled meeting of the calendar year, with the exception of 2017.
Hold on, just be less prescriptive. The elections will happen in the last quarter of the year.
Oh, he's got it less prescriptive than what you just said.
What did you say? I thought you said the second last week.
Then you're leaving
No.
September out to say last quarter.
I thought you said second last meeting, so I misunderstood that.
No, he didn't. He just said prior to the last meeting.
Let's hope that's running.
This is crazy. Elections will be held prior to the last scheduled meeting of the calendar year, with the exception of 2017.
I think that's fine.
Please.
Just making a point, the way the language reads, you could hold the elections the hour before the last scheduled meeting.
Yeah, so
That's
what?
okay. They're okay with that.
Well, as long as everybody,
Or-
it's
well-
not the meeting before the
Well,
last meeting.
The other thing we could do is you could hold it prior to opening the floor at the last
Right.
meeting.
As long as before the meeting convenes, you've met the.
But it can't,
language.
because you can't actually hold the vote without a quorum at a meeting. Right?
Has to be scheduled.
So a meeting prior to the last meeting.
Which is what he said.
Right.
I think you're okay.
Elections will be held prior to the last scheduled meeting of the calendar year, with the exception of 2017. Nominations will be accepted electronically prior to the meeting, may also come from the floor, as long as the nominee is present and concurs. So if you step out of the room to use the restroom, we can't vote you into anything. Okay. Are we good?
Yes.
Send that
Need
out
some
to the,
We will send that out to the group. That needs to be voted on first at our next meeting, then we can hold elections.
so
All
I
right.
believe
I thought,
you have to
we
vote
could've-
down how it's currently written and send it back.
Why can't we
Why?
adopt these today?
Why?
Because they.
No, no, here, hang on a second. Why?
Because you have to either accept or refuse the amendments as you are reviewing them.
According to?
Robert's rules?
So, 5.4.1, current edition of Robert's Rules shall serve as the basic structural outline for the meetings. Strict adherence to Robert's Rules is neither expected nor intended. I would say based on that continuing to work through these problems at this table and voting would make reasonable sense unless there is a single person at this table who thinks that we shouldn't just fix this.
I think these
Once and for all.
modifications have been out there, and they were discussed at the last meeting.
Yes.
They've been out there and distributed to the committee. I think it's totally appropriate to adopt them if the committee so thinks it should today.
I would agree, and I'd furthermore say, these adoptions don't mean we can't change things later.
Correct.
So let's go ahead.
So I would make the motion to adopt them as amended unless there's an objection.
All in favor of adopting 3.4 as I just delineated? Any opposed? Thank goodness. Okay. In 4.1, there are two different options. Unfortunately, I can't see them that well. So the first of the options,
The red copy.
do you have a red copy? Oh, thank you. There are two options in 4.1. The first is the one that we had discussed and written out at this table. The second was one that we reviewed and continued to think about it afterwards. The goal with this was to make sure that we were making as much inclusion of our body as possible without another body being beholden to the membership of this body. Members will be required to attend all meetings of the REMAC. The names of members who do not attend 2/3 of the scheduled meeting in a 12-month period will be brought to the attention of the, originally it used to say Regional Council, now it says Chair, by the Program Agency Executive Director. Members not in compliance with the attendance requirement should be informed by the Program Agency Executive Director and asked to offer an explanation for their absenteeism prior to their absenteeism being brought to the attention of the REMAC membership, who may choose to vote for expulsion by a 2/3 vote. Physician and hospital representatives shall have their hospital administration notified. That was the version that we had read through here. The alternative one that I think reads better, and I believe has the same intention, members are expected to attend all meetings of the REMAC. Members not in compliance with the attendance requirements shall be informed by the Program Agency Executive Director and asked to offer an explanation for their absenteeism. The chair, after reviewing the absenteeism with the executive committee, may bring a vote for expulsion to the REMAC membership. Formal expulsion must be by a 2/3 vote. Physician hospital representatives shall have their hospital administration notified. That keeps the decision in the REMAC. The responsibility for notification of the REMAC chair falls to Tim, and then this body can expel somebody, but only by a 2/3 vote. And that 4.1, the second version of 4.1 is the one that I think is more reasonable and easier to work with. It gives the decision on whether or not somebody can even be brought to expulsion to the chair, where I think it really should lie. I think that's a reasonable decision. But the chair does not have to bring it. If somebody suffers a significant family issue or a health issue and can't make half the meetings in a year, I don't think they should be expelled. That's not right. But that's a decision that future chairs can make. Does that seem reasonable? So I think what we have to do is vote down the original version of 4.1 that we had agreed on last time, and vote on the other version of 4.1. All in favor of not selecting the original change to 4.1? Thank you. Yes? All in favor of the updated 4.1? Thank you. It is much nicer having it read. Thank you. Meetings. To the extent practicable and in compliance with the Public Officers Law, Open Meetings Law, the REMAC shall. All in favor? Thank you. There shall be no fewer than 5 meetings per calendar year, in case we miss one. Thank you. More housekeeping. 5.4.3, in compliance with removing NYS, leaving open meetings law. All agree? Thank you. 5.4.4, all voting and alternate members may attend the executive session, adding all and alternate members, so any physician members can participate. All agree? Thank you. 7.1, 7.0, and 7.1. There was discussion here at the table that we should not have regional council approval for the election of the EMS Systems Medical Director and CMAC representative. That information that we were given regarding that was actually incorrect. We must have council approval for our CMAC representative. That's required by statute. That's why the language has changed here. So the REMAC will elect a physician from the voting and alternate physician members of REMAC to be the Regional EMS Systems Medical Director, aka Regional Medical Director, and Regional Representative to the State Emergency Medical Advisory Committee of the CMAC. The nominee will require regional council approval, and then responsibilities are unchanged. All in favor? Thank you. Alternate CMAC representative will also be selected and approved by the regional council. All in favor? Thank you. Executive committee. The REMAC will have a standing executive committee that will be responsible for emergent review of issues arising as needed. It will consist of the chair, the vice chair, regional medical director, and the chairs of the QA committee and the academic committee. All business of the executive committee must be reported to the full REMAC at its next scheduled meeting. All agree? And that, ladies and gentlemen, is that. All in favor of adoption of the bylaws as read and reviewed? Any opposed? Thank you all. Yes, we do. I saw counting of heads in the back. All right, thank you very much. Does anybody have any business from the floor?
There was, you guys probably did this at the academic committee, but I was just reviewing the data that was on ambulance arrivals.
Yes.
Oh, we blew right by it, actually. Let's review that really quickly.
Actually, I have to go. I'm gonna be on a phone meeting at 5 o'clock, but there's one cell of data that looks incorrect. And if you look at, under St. Peter's Hospital, the first column, the first cell of data at the top, it doesn't add up. Everything else looks correct from a mathematical point of view. But 724 out of 1097 isn't 42%. You know, it's,
Right.
and then 289 over 1097 is not 3.4%. That cell of data is not accurate. So I just want to point that out. But I have to go, so I have to excuse myself.
You're right. Thank you.
Just FYI.
Right. There were a number of things that are still to be worked on with this.
But this is great data, Dean. I mean, this is really good. Data like this is really important for us to be able to deal with, you know, operationally.
I'll check into what happened here.
Thanks.
Jim?
The applications that were submitted for membership to this, stand where?
Stand in my office, subject to formal adoption of these, then those applications will go to the REMSCO for review and approval, and then we'll go back to you guys. So, I guess my question right now is, if these have been formally adopted today, can I add that to the REMSCO agenda
Please.
for the end of this month?
Please do.
Okay, I'll have to circulate those. There are a lot of them. That'll be the REMSCO's job to review all of those and come back informed in October to vote on those applications and make their selection processes.
Excellent. Any other business?
Just an informational point, Samaritan's opening date has been pushed back yet again, now December 7th, just to tell us that we're ready.
When is St. Mary's closing date?
Well, it doesn't really close, it turns into an urgent care center, and that would be December as well.
Hopefully not if they can overlap them.
No, so there is going to be no overlap at this point.
Okay. Thank you. All right, folks, thank you very much.
Once you got the budget and stuff, I can order them the next day.
Does the reason
You're looking quite nice.
Oh, yeah.
just back
I don't know what happened.
Oh,
Really just speaking from the administration, and I do a lot of administrative stuff. It's been really difficult.
You may want to turn off your camera.
Doing that well, and I think this is unfortunate. This is unfortunate.